Good. Okay, good. So we're here with Dr. Stephen Blazar, who's a fellowship-trained spine surgeon at Care New England. And we're going to be talking about the disc herniation with radiculopathy patient. So this is a patient that comes to the primary spine practitioner. The primary spine practitioner makes the diagnosis, does primary spine care management, and you reach a point where things aren't going well, and it's time to have the conversation with the patient about this is possibly a surgical situation. We're going to go on to the next step. So Dr. Blazar is going to give us his input on what we can expect from the patient encounter when the patient asks us questions about what they should expect, how we can give them advice, and how the spine surgeon goes about the process of managing that patient, both from a communication standpoint as well as a surgical standpoint. So, Dr. Blazar, my first question for you today is, what are the decision-making clinical factors that you utilize to make the decision as to whether to recommend surgery in a patient with a disc herniation situation with radiculopathy?
Well, a lot of it goes to the history first, and that's really the crucial part. Of course, you know, assuming that the patient comes from someone like you, the history will be pretty clear and pretty obvious as to what was done. But in order to be sure, I always ask things to make sure that how long has it been going on? Is it progressive? Are you having any new weakness, especially, or any new bowel or bladder problems? And exactly what's been done. Have you had chiropractic? Have you had physical therapy? Have you had injections? Have you had nerve stabilizers, gabapentin, Lyrica? Have you had epidural injections? Have you had traction? What have you been doing? So that gives me a whole lot even before I touch the patient or talk more to the patient. So the keys for me are, you know, have non-operative care treatments been used, or has the patient declined them? And if so, why have they declined them? If someone hasn't had an epidural injection, that doesn't mean anything to me, because in many cases, epidural injections don't work, 30% average of working. But if you have a free fragment, things like that, they're never going to work. Is a patient needle phobic and they'd rather have an operation than an injection? Well, that says a lot too. So sure. The history is really, really important for me to know, because when patients come and see me from non-spine practitioners, you know, half the time they come in with an MRI, and what happened? Oh, yesterday I fell and I twisted my back, and I have an MRI. That's a different sort of thing than someone from you. So in coming from a primary spine practitioner, I would expect all of that to have been done, or at least discussed and discarded for whatever reasons.
Yep. Yep.
So obviously anybody with a foot drop, it's not an automatic surgery. You have to say, okay, how long have you had this foot drop? How many years? You know, if you have a foot drop for a year, you know, and you have a back operation, that's not going to do it. I mean, if you think that a discectomy is going to make your limp foot function after a year, it is just not going to do it. Mm-hmm. It'll make the picture look better, mm-hmm. but it won't really help. So,
yeah. So you're talking about the importance of getting to what the patient's expectations are and making sure their expectations are realistic. Because if they're not, and we don't find out, that could result in a big problem. Is that right?
It's a nightmare when patients, you know, and some people are, I'm sure we've all had this, you know, somebody comes in a wheelchair and then post-operatively they come in and they're walking, and I said, wow, that's really fabulous. You look great. They go, no, because I used to run 5 miles a day. Mm-hmm. Well, you're 90.
Yeah.
You know, you were in a wheelchair a week ago.
Yeah.
You know, and that's the person that shouldn't have an operation, because you're never going to make them better.
Right. Yeah,
so I think realistic expectations say, like, I say, all right, what is it you want to get out of this? What is it? You want to return to being a SWAT team member after a 6-level fusion? Probably not.
Right.
You want to be able to walk and ride your bike and swim and play with your kids and, do your regular stuff. Yeah, that's a pretty good chance. So the
Great.
conversation is actually important.
Yeah, that's great. Yeah. So again, to the patient with the disc herniation with radiculopathy with a fairly straightforward discectomy situation. So you bring the patient into the operating room. Can you walk through briefly the steps that you take then, the actual process of performing
Sure.
that discectomy?
But just before that, in the office, though, I actually take the MRI out. A picture's worth 1,000 words. And if you've done it, which I assume you have in your office, and then I do it and I repeat what you've said, then the patient really sort of gets it. Okay, these are two different people saying the same thing, so maybe it is true. And I think it's very important to have on the screen in front of the patient the split screen where you have the sagittal on half and the axial on the other half. And I like the T2 images because they show up better. They're not subtle like the T1. So you need someone who's never looked at an MRI to look from across the room and say, holy shit, look at that. There's a big thing sticking there where it shouldn't be. That's really impressive. And then you take a model and you show it sideways and you show it transversely and you show it next to the picture so that they can say, oh, there's the disc or there's the disc. And their whole mindset completely changes when you can show them something they can see as opposed to a herniated disc, or even worse, a bulging disc. So, oh, I have 8 bulging discs. Wow, it's amazing you can walk. So, you have to be able to show them. So back to your question, I just wanted to impress upon everyone that it's very important not to just say, well, I've seen your MRI and it shows a herniated disc. I'm sending it to the surgeon.
Yeah, and actually before you go to the OR, you also made the important point that if the patient is encountering 2 different professionals that they trust, and both of them say the same thing to the patient, that increases their comfort level and confidence that, oh, I'm in good hands, and I'm more confident that this is going to be a good outcome. Wouldn't you say that?
Right, because, and if you send somebody to another person, there's a lot of that, well, what do you guys got going on? I mean, it's not like lawyers. You don't cheat. It's, it's a real legitimate referral that you don't get a kickback. And whenever I send someone to another person, well, I have nothing to, this is just a person I trust. I'm not related to this person. I trust this person, or that sort of thing. Or if I sent a number of patients to her or him and, they've done well, and I think you'll enjoy it, So I think that's a really important thing to say, that you've had experience with this person and they do a good job. And that's all people want to hear. They do a good job. This is the person I would send my family to. Right. And that makes patients feel a whole lot better, as opposed to, hey, I heard about that. I saw him on TV. He was on like the Health Minute, and he looked pretty good. So you want to say, look, I know this guy. I've sent patients to him or her, and they do a good job. And this is who I would go to.
Yeah, good.
So
okay, so to the operating room. Then now you're going to perform the discectomy. So can you walk us through what exactly you do in that process?
Well, the first thing is the table that we use. There are tables and then there are tables. The bottom line is it doesn't matter exactly what kind of an apparatus you use. The key is to have the abdomen free. You do not want pressure on the abdomen because that increases epidural bleeding, venous congestion. So, there in the old days, like when Dr. Murphy was younger, in the old days when we were starting out, we used rolls. We would just roll up big blankets and put them on either side, and there'd be a small space where the belly would go through and wouldn't push down. But we don't do that now. We have $80,000 tables. They're called Jackson tables, and those are tables that have pads are on the breast or on the iliac crest, and everything else is free, and they're carbon fiber, so it's radiolucent. And so you need to place the person on a table, either a Jackson table or a thing called a Wilson frame where you can bend the spine. You need to be able to have the type of positioning where you can alter the normal anatomy of the spine. So in discectomies, for example, you want to put the patient on the table so it's not in the lordotic position. You want it in the flexed position because it opens up the interspinous area, makes it easier to get in. If you operate on someone for a discectomy and they're in full extension versus full flexion, that's a whole different operation. So even something as silly as what kind of a table we're using is actually important. So you select the proper table. For example, with a fusion, you want the person in extension because you don't want to fuse them in flexion. They'll get a flat back. In discectomies, you want to put the patient in a flexion position. I think I've tortured that enough. So that's the table. So then you do the prepping and the draping, and there are so many different ways to do discectomies, but the common denominator has to be visualization. Now, you have to have a headlight, you have to have loops, which is expanded field magnifying glasses, or you have to do it with a microscope. And there are pluses and minuses of both. So the bottom line is you need to have good lighting and good visualization. Then you have to decide. In the old days, they would make a huge incision and say, okay, where is this space? Probably try not to do that as much. So you need to really, think twice, cut once. So we use fluoroscopy, C-arm, image intensification to identify the level. There's no reason to make an incision this big for a discectomy where the incision could be this big. So I traditionally use a minimally invasive approach. So in order to be minimally invasive, you have to target and go to the right place. So you bring the C-arm in the lateral plane because the patient's prone, face down, and you're bringing the C-arm in the lateral plane. So the patient is this way and the C-arm goes here. And you put a marker of some type. I happen to use a K-wire, long, skinny needle wire. And you do it on the outside of the skin, and you take a picture. So that's overlying that particular disc space. Then you go up to the back, and you know the exact spot where the disc is located. So you can make an incision that's much more judicious by knowing where you're starting. So you make the incision, however you do it. I use tubes and look through a fiber optic lit tube, but people do all sorts of different things. And many people find that the minimally invasive fiber optic approach is better than the traditional midline approach because you're not taking down the ligaments from their attachments onto the spinous processes. So if you can just make a fascial incision over to the side, as opposed to a midline detachment incision, the thought is that the short-term healing is better, but no long-term result differences are noted.
Got it.
So you make the incision, and you get down to the lamina. Now, if you're doing it from the midline, you make the incision through the fascia, and you pull the musculature with the fascia attached to it out to the side and put a retractor in, something to hold those tissues away from the lamina. So you want to be able to see the overlapping lamina because you're going to go in between. Once you see that, you visualize it, you make sure you're in the right spot, check twice, cut once, you put a marker in, you bring the C-arm in, and you take a picture. Yes, I'm in the right location. Best operation in the wrong location doesn't work. So, words of wisdom. So what you need to decide beforehand is, where is this disc in terms of, is it coming out directly posteriorly? Is it a free fragment that has traveled inferiorly, rarely superiorly? Is it in the foramen? And it makes a difference because if you're doing your normal discectomy, what you're going to find is that you do a removal of a little bit of the bone along the inferior aspect of the lamina that's above. So if it's L5S1, you're just removing a little bit of the bone along the inferior aspect of L5, curvature. You just make a hole so you can see it. If, however, you notice that the disc is a free fragment and has traveled, then you may need to not just take a little bit of the bottom of L5, you may need to take a little bit of the top of S1, so to make it a bigger visualization. The run-of-the-mill posterolateral disc herniation at L4-5. We're removing probably about 20% or less, or 25% of the lamina of L4 on just one side. So herniated disc L4-5 on the right, I'm going to remove just a fraction of the lamina on the right side only. I am not going to remove the facet joint. I don't even want to bother with the facet joint. I'd like to leave it alone. Facet joints are our friends. So we don't do that. So we be careful to do that. So you need to remove part of the lamina. Now, before you remove the lamina, however, the ligamentum flavum has invested its fibers into the inferior aspect of L4. So we take a curette and we scrape the ligament off. We separate it from the lamina and the ligament. We take the separation. Once you get the separation, you can then use a kerrison. I think I have one here. Oh, I do. This is a kerrison. Pretty cool. So the way it works is that, oh, here's a spoon. The way it works is you put this kerrison in between the bone. And as you take a bite of it out, you know, see, I don't know if you can, does that show up?
Sure. Yes.
Okay.
Yep.
So, and then here's the piece that comes out. So we do that progressively. See, show and tell. It's orthopedics. When in doubt, force it out. So we remove the bone, and pretty soon after we've done that enough, we have removed a little bit of the bone from the inferior aspect of the lamina above. The ligamentum flavum is still there, though. Why? Because it protects the underlying dura while I'm taking something like this and chopping bone. Mm-hmm. So it's not a chiseling of the bone, it's a biting, it's a removal of the bone.
Got it.
Okay?
Yep.
So once that's done and we've made our laminotomy, then I'm looking at the ligamentum flavum. I then remove the ligamentum flavum with the same sort of process, but if this is the ligamentum, I just come in here and just remove pieces of the ligament. And so I use this same rongeur to remove pieces of the ligament, and now I'm looking at the dura. Now, if you're not a spine person, everybody says stay away from the dura. I love to see the dura because once I know where it is, I then know where to not do bad things. So now I'm looking, and the reason that I did the inferior aspect of the lamina above is because that's where the disc is. The disc is higher. The disc is not exactly in between the two lamina, it's higher. So you've got to go up to get to the disc space. Now, no matter where the piece of disc is that is causing the problem, you need to go into the disc space. Why? Because just because there's a free fragment of disc doesn't mean there are no other fragments of disc that could pop out. Remember, there's about an 8% recurrence rate really fast. I actually saw somebody get a recurrence in front of me in the hospital, walking down the hallway the day after surgery. All of a sudden, a piece fell out, guy goes to the floor. Wow. So it can happen. But remember, discectomy is not removal of the entire disc. It's removal of the piece of the disc. It's really a partial discectomy. Mm-hmm. The only way to remove the entire disc is to go in through the abdomen. And that's really frowned upon when you're approaching it from behind. So you got to go and just take the piece out. So you got to check into the disc. So now what I'm doing is I'm moving the thecal sac over towards the midline to allow me to see what's beneath it, what's ventral to that location. Now, there are always epidural bleeders, so you got to be very careful. And we use a bipolar cautery where we take a little pinch in between, and the current goes and it zaps them. You don't want to use the unipolar cautery because that cauterizes in a whole big circle, and that includes the nerves. You want something that's just going to cauterize between the pieces. So we move the thecal sac, and we control the bleeding. The higher up in the spinal canal you go, the bigger the epidurals are, the more crowded the space is, and the more bleeding is encountered. Mm-hmm. So you have lots of room at L5S1 because you just have a few fibers left and you have no room at L1 too. Again, you got to remember these things so that you don't say, oh my God, I can't see. You got to be prepared for that. So we control the bleeding. You control it with electrocautery or some gel foam, which is cellulose, and it coagulates blood, and you just push it over to the side so you can see. So then you very gently retract the thecal sac towards the midline. And now you're looking at the annulus if there's no free fragment sticking out there. Many, if not most times, you'll see a good section of disc protruding out and directly impinging on the nerve root so that you can actually feel a big bump in that area. You can see it and you can feel it. So you're moving the thecal sac over to the side gently, and you're seeing a big bump. That's the annulus with the disc herniation. You put it, so then we have to incise the annulus. You can make an incision, a cruciated incision, or a box or whatever. And many times the disc will start to ooze out like a prom zit. So you'll see this thing sticking out, and then you'll take pituitaries or picker-uppers, and you'll start to pull pieces of the disc out. Now, you're looking straight down into the disc. We all know that the disc is much longer, much wider than we're going to see because we're only made a little hole to see. So we have to have a way in which to go into that hole and then go to the right and to the left. So we have biters that, the grabbers that go right and left and up and down so we can check all the areas. Now, you're not going to be impressed most of the time by the volume of the disc. The amount of disc you take out is not proportional to the pain. People with the smallest little discs that you look on the MRI and you say, oh, come on, grow a set. This is not a big deal. It is, because when you go to the beach, if you get a pebble in your eye, doesn't matter how big it is, it hurts. So the littlest discs, if they're touching the nerve, it's like being almost pregnant. If it's, you're either are or you're on. If it's hitting the nerve, it hurts. And so don't be impressed if it's a small disc and you go, oh, there's nothing. So you remove all the pieces of the disc from that are loose. Now, you're not scraping the end plates. The old days, they used to take big curettes and scrape the cartilage, and that just caused significant degenerative disc disease. And we all know that even a small disc herniation that's had surgery, later on you're going to see those changes on the MRI showing degeneration and narrowing of the remnant of the disc. So your job is not to make that worse. So you take out whatever loose pieces are there. I have a little technique where I put in a special little catheter attached to a syringe directly into that hole in the disc space, and I irrigate very powerfully fluid, and that just cleans out, and it's amazing how many pieces will come out. So the bottom line is you need to be sure in the hole into the disc space that you have cleaned out whatever is loose. Once you've done that, then you can go outside of the annulus, outside of the disc space, and search around along the inferior body of the vertebral body above. In this case, it would be L4. And right below it, on the superiorly, along the body of L5. We do that with a hockey stick, something that can go right across the midline to feel. If you feel big bumps, you say, well, that might be a disc there. And also, it's important to go into the foramen. So you let the thecal sac go back, and then you go down distally a little bit, and you follow the nerve root. You need to see the nerve root. You follow it to the foramen. So you're going under the pedicle. So you're following that nerve right on under the pedicle. In addition, many herniated discs can go inferiorly, so they can hit the shoulder of the nerve, or it could hit the axilla of the nerve. So you need to feel into those areas to make sure there's nothing. And that's the big fear of spine surgery is, did I leave a piece? I got disc, but did I get the problem? And so you really have to make sure, and it's not a big deal to make sure that everything is out of there. Then once you've irrigated, then you put in some kind of anticoagulant. I mean, some type of coagulant. So you want to make sure, because epidural bleeding is never a great thing, especially when you've closed up the tissues and now you have a closed space. And if you have a lot of bleeding in a closed space, you get the equivalent of a compartment syndrome where you get pinching of the nerve, and that's really bad. So we make sure it's bone dry. Make sure that there are no dural leaks. Incidental durotomies is what we euphemistically call them. And that can happen, and you just sew them up, and there are all sorts of ways to do that. So once you've done that, then you let the musculature fall back in to cover the laminotomy. You don't have to do anything special to the dura. Some people put a piece of gel foam on. The old days, they would take a little bit of subcutaneous fat. You can leave it open, it's up to you. But the muscle and soft tissues will close right over it, and then it's a skin closure.
Yeah,
and of course, the invoice.
Yeah. Yeah, and well, the interesting thing about this is that, what we're talking about here is what many would call a simple discectomy, but it's much more involved than one might think, even though it's considered fairly simple in terms of, in comparison to other procedures perhaps, but there's a lot involved in it in terms of what you're doing during that process.
Right, there's nothing you can't make worse with an operation, so people need to know that the complications with a simple operation are still pretty significant. Yeah. Foot drop, dural leak, headaches, blood loss, infection, recurrent disc herniation, scar tissue, persistent pain. There's nothing that's simple. Mm-hmm. It's simple compared to a 5-level instrumented revision, fusion, and correction of scoliosis, but it's not simple in relation to life.
Right, yep, got it, yep. So let's go back then to the office setting. So the patient is with the primary spine practitioner. Again, they have a disc herniation with radiculopathy. The primary spine practitioner has worked with them and things aren't going well. So it's time to talk about, again, have that conversation about the possibility of a surgical procedure. The primary spine practitioner is recommending to the patient that I would like you to see the spine surgeon. What would you want the primary spine practitioner to tell the patient, or the content of that conversation, to prepare them for the visit with you?
The first thing is, just because you're seeing a surgeon doesn't mean you're having surgery. This is a consultation. This is a discussion to see whether or not surgery could help you. Patients come in saying, well, I'm seeing a spine surgeon, so I'm having an operation. Whoa, maybe we could even talk to each other and look at the MRI. So this doesn't mean you have to have an operation. Mm-hmm. This means I'm sending you to someone because the non-operative things haven't worked, and we're going to find out whether or not maybe surgery could help you. You don't have to have an operation, just have a conversation. And this is someone that can go over the MRI again with you, explain to you the surgery if you and that doctor feel that surgery can be helpful, and then you decide what you want to do. You're not committing to have surgery, and just because you're seeing this person doesn't mean you are a good candidate for it. You may not be. Mm-hmm. So you really need to lower the expectations. Some people come in and say, well, what time I have my surgery? So, I don't know. I haven't even decided. Perhaps we could, look at the MRI. Yeah, right. So yep. There's that thought that once you're referred, you have it.
Right. Got it.
Yep. So, and then say you got to ask. You say, I expect you to ask, what's the success rate? What are the complications? What's the post-op going to look like? These are things that the surgeon should be able to have a conversation. And once you have all that information, then you make a decision about what's best for you.
Well, then speaking about the post-op, so and I realize, of course, every patient is different, so every situation is different, but what's the typical process that you expect with regard to post-op, the duration of time, their activity recommendations, et cetera, or post-op rehab? What are your typical recommendations with regard to
that? Typically, this is done as an outpatient. So people are out of the hospital in a few hours. And they all seem pretty surprised by that. Well, I had an uncle who was there for 6 months, that was 1910. So, it's you're out of the hospital that day. And I think that's a very reassuring thing for patients. patients. This is an outpatient procedure. You're going to be home after lunch, that sort of thing. You'll be walking that day and they're startled. So you got to reassure them that they're not being in the hospital. They're not going to get MRSA and all that sort of stuff that people are justifiably concerned about. They're going to be up and walking that day. Now, I say like for the old people, I'll say, well, you're not going to be Fred Astaire or Ginger Rogers that day, but you'll walk. And what I do is I give them a corset. Every study shows that corsets don't do anything for big spine surgery, but this is for comfort. Because even if you make a little incision, if you're walking down the street and somebody walks by you and stabs you in the back with this, it's going to hurt for a few weeks. So I tell them that the incision, even though it's a little one, doesn't really matter. Skin heals the same amount of time. It's going to be uncomfortable, and you're going to remember you had an operation for a handful of weeks, but you'll still be able to walk around. I don't want you lying in bed, eating bonbons and watching reruns of the Flintstones. You need to be up and walking around. So I say, I encourage you to walk. And my post-op instructions, in order to keep it simple, is after each meal, go out for a walk, beginning 5 minutes at a time, and increase 1 house more or 1 minute more every day until you're walking 20 or 30 minutes 2 or 3 times a day. Now, most people don't need a cane or a walker, but if they're older, they do. But then older people don't usually get herniated discs. But, that's okay to use. People say, well, can I do stairs? Yeah, you can go up and down stairs. Has never been shown to cause herniated discs. So you can do stairs. You can go outside. You can go for a ride. I don't want you driving right away because you're taking narcotics. And unless you're in high school, you can't drive taking narcotics. So you got to be able to do that. You can't be driving and taking narcotics. And also, it's going to hurt to twist, so you're not going to be able to see around you as well. So when you're not taking a lot of painkillers or any narcotics, and you're able to walk around and you want to go for a short ride, that's okay. Now's not the time to travel around the country. So progressive walking, and I do that for a handful of a few weeks. By 3 or 4 weeks, a lot of the surgical site pain is better. Not 100%, but you got to hang the crepe. So I tell them many times it can take up to a year to get as good as you're going to get. You may need post-op therapy, chiropractic, whatever, but you may or may not. And you'll see how you feel. At that point, they're well familiar with the exercises that they've been instructed in. They're well familiar with chiropractic, physical therapy, and modified positioning. So they are comfortable getting back to that, and then as tolerated over a handful of weeks, getting back to the regular stuff. Now, I don't have them do repetitive or heavy lifting, for example, in work, unless they've had a good strengthening program. For the average person who doesn't work or do anything hard, you don't need a formalized therapy program. Chiropractic is good for decreasing the soft tissue inflammation and increasing flexibility. So that's okay, but as far as going 3 times a week for someone to show them how to bend, not really necessary. Workers' injuries, for a whole slew of reasons which you are well familiar with, they need a much more rigid, structured, supervised, and objectively measured post-operative care.
Yep, got it. Good, fantastic. Good. So, so last question, but an important one. So the patient sees the primary spine practitioner, has a disc herniation with radiculopathy. The primary spine practitioner is working with them. They've got a somewhat mild motor loss, 4 over 5, let's say. What is the thing? And of course, the primary spine practitioner is monitoring that carefully. What is the thing that you would say would be the important thing that you want to look for to determine, are they at the point where I think it's time to talk to the surgeon with regard to the motor loss specifically?
Well, of course, anything progressive is not okay. Now, obviously, the first day you have it is going to be, you can't say, well, that's progressive. It was 0 yesterday and it's there today, because it may improve. But I give it, I need to see progress over 7 to 10 days. Medrol dose pack, gee, is this helping? Is anything we're doing helping? And they're going to say, no, I'm getting progressively worse. That's more of an urgent referral, progressive motor weakness. But someone who is not falling, tripping, can tolerate a mild foot dorsiflexion weakness, for example, more so than someone who's dragging their foot or tripping. So if it impedes your normal ambulation, I'm not talking about climbing Mount Kilimanjaro, your normal ambulation, like, gee, I can't go to the store because I keep tripping. That's something that needs to be sent right away. Somebody who is obviously bowel and bladder, but that's a different story. But in terms of radiculopathy, progressive loss, a loss that really interferes with normal activities of daily living is really a problem that needs to be addressed earlier than later.
And again, every situation is different. Every patient is different. In a rough estimate, when we're talking about progressive motor loss, the extent of the motor loss and the duration of the motor loss, approximately how long would you recommend that the primary spine practitioner uses in terms of a time frame or an extent frame to decide, I think it's the time where I would call this progressive motor loss. It could be days, weeks, months. Obviously, that it's different for different people. But again, on average, what would you say would be the recommended duration or extent that would trigger us to say, I think it's time to see the surgeon?
A foot drop, come right in. I'm not talking about a little bit of weakness or, gee, I can't pick my foot up as great. Foot drop, that's it. Obviously bowel and bladder, that's it. That's immediate. So foot drop is right away. Someone who has a 4/5 weakness, it's subtle, it's there, but it's subtle, and they're noticing a little bit of fatigue when they're walking, but they're not tripping. That's something you can sit on for probably 3 to 6 weeks, depending. If I'm walking around, but my foot feels tired, and you see a 4/5 strength, you can sit on that for 4 to 6 weeks. That's reasonable. Gee, it was 5/5 last week, and it's 4/5 this week. Next week it's 3/5. That's not. You don't wait. It's not an emergency, but you don't say, well, let's see how this turns out. I got news for you. The end of the movie is not happy. So you want to get that done super. But people can live with 4/5 strength, and they send them to rehab and E-stim on the L5 musculature and therabands and that sort of stuff. And a lot of times, after 6 weeks, it settles down. So in the first 6, I think you get the first 6 weeks to live with a modest weakness.
Got it. Great. Well, this has been very, very helpful, Dr. Blazar. I can't believe how
it isn't helpful for you. You know all this.
I know. This is for the audience.
Oh, okay. Sorry.
This is great for the audience. People are going to really benefit from this. So I really appreciate your time, and we hope that in the future we'll be able to spend some time on other topics within this spine program, because it's so important for primary spine practitioners to understand what things look like from your world, because we're all really in the same world. So I really appreciate your time.
I agree.
Okay.
Anytime. I'm happy to help.
Okay, great. Thank you. Great. Bye.